In this session, I'll be discussing about diagnosis and diagnostic tests. So before we go into the topic, let us see what is a diagnostic test. Diagnostic test is any device or any clinical tool that reduces the uncertainty about the state of disease. Any measurement aimed at identifying individuals or groups of individuals who could potentially benefit from an intervention. So this is the definition of a diagnostic test. So the diagnostic test may be in the form of laboratory tests like hemoglobin, CEA, alpha fetoprotein, amylase, or measurements like pulse rate, blood pressure, temperature, or clinical signs like McBurney's sign, Murphy's sign, or criteria like the Jones criteria, Manning's criteria, or imaging like an ultrasound or X-rays. So any of these can be a diagnostic test. And diagnostic tests, what they do is that they reduce the uncertainty about disease. But we should know that the diagnostic process is imperfect. Tests are seldom 100% accurate, and they should be better than random. No, they should be better than just tossing a coin and telling whether it is having disease or cancer or not. So they should be better than random, and they are seldom 100% accurate. But how do we know the accuracy of a diagnostic test? A test accuracy is measured in relation to a better method of knowing whether the disease is present or not, or whether what is the method of arriving at the truth. And for this, what we use the gold standard. The gold standard, it can also be called the reference standard or the criterion standard. These can be simple tests. For example, it may be like anti-HIV IgM to diagnose acute hepatitis A. It may be a simple blood test, or it could be an invasive test like a biopsy, angiogram, laparotomy, and so on. So this is the diagnostic test. It is with this diagnostic test that we compare a diagnostic with the gold standard, that we compare a diagnostic test. And usually the test and disease are expressed in a 2x2 table. For example, we know that there are the disease, there are two columns of disease is present or absent, and the two columns of the test, disease is positive or negative. When the disease is positive, when the test is positive in a person with the disease, we call it as true positive. When the test is positive in a person without the disease, we call it as false positive. Similarly, when the test is negative in a person with the disease, it is false negative. When it is negative in a person without the disease, we call it as true negative. So this test can be expressed in many ways. Sensitivity is the term given to the true positivity, the number of persons with the disease who have a positive test. So you know that sensitivity is calculated by A in this column divided by A plus C, that is sensitivity. Specificity is the number of persons without the disease who have a negative test. So it is a number of persons who give a negative test, that is D, divided by B plus D, that is sensitivity and specificity. As simple as that. So I'm just giving a table from a recent article. They have given the, let's say if you take ALT alone, the diagnosis of stage 2 hepatitis, and if you take ALT more than 70 as positive and below 70 as negative, 70 and below is negative, it has got a 50% sensitivity and 60.7% specificity. So I think that there is another interesting test called the hypertension, the hair test. H stands for hypertension, A for LNA, ALT, and IR for insulin resistance. If more than two of these parameters are present, see that it has got 80% sensitivity in diagnosing stage 2 hepatitis and almost 89% specificity in the diagnosis of non-alcoholic stage 2 hepatitis. So we'll come to the other things later. So one of the simple things that we use is what is called the snout. A very sensitive test, if it goes on testing everything as positive, the test is useful because if it is negative, you can safely rule out a disease. Similarly, a highly specific test It's called spin. If it is positive, it rules in a disease. So that is the importance of highly sensitive and highly specific tests. Next, let us see how the prevalence of the disease influences the characteristics of a diagnostic test. Let me take a scenario in which there are 100 persons with the disease and 100 persons without the disease. So in this 200 persons, 50% have the disease and 50% do not have the disease. So if you have the parameters, 80% sensitivity and 80% specificity, we know that the chances of a person having a disease in the presence of a positive test is 80%. That is what is called the positive predictive value. The chance of a person with a negative test not having the disease is again 80%. But let us now change the proportion of the prevalence of the disease and see what happens to the positive predictive value and the negative predictive value. So this is a population where there are 100 persons with the disease, with 400 persons without the disease. That is, the prevalence is only 20%. Prevalence of the disease is only 20%. So among the 400 people, because the specificity is 80%, 320% will have a negative test and 80% will have a positive test. So if you calculate the positive predictive value in this population, it will be 50%. And if you calculate the negative predictive value, it will be 94%. So what I want to present here is that once the prevalence comes down from 50 to 20%, the positive predictive value comes down. But as the number of people without the disease increases, the negative predictive value increases. So that is the importance of prevalence in the predictive values, positive and negative predictive values. But we should know that sensitivity and specificity are not influenced by the prevalence. So how do we increase the positive predictive value? By a referral process. So if a test is done in a referral center, like if you have got a person with a liver disease, you're referring to a GI center, the positive predictive value of liver disease in that center will be more. Similarly, you do it in a selected demographic groups. For example, when a 10-year-old person comes with a 10-year-old boy comes with chest pain, you don't do a TROP-T or ECG and things like that. And then, so you do it in a specific demographic groups and specific clinical situations. So when you use the test in these situations, you increase the positive predictive value of the test. So that's why the tests have been compared to the hoofbeats. When you hear hoofbeats, what do you think of? When you think of hoofbeats, we think of horses. And we don't think of zebras because the probability of this being a zebra are low. That's why the interpretation of a diagnostic test has been compared to the interpretation of hoofbeats. Now, let us take the situation where there is HIV screening of health workers. Let's assume that the test is 99% sensitive and 99% specific. Let's also assume that about in the population, the hypothetical population, 1 out of 1,000 person is having an HIV. Suppose you do this test with 99% sensitivity and 99% specificity, you will find that out of the 1,000, only one will be having the disease. He will be positive for the disease. But out of the 1,000 persons, you know that 1 out of every 100 person who is normal will have a positive test. So in 1,000, you will get about 10 persons who are positive but without the disease. So this is what we should know, that in about the 11 persons who are positive for the disease in this 1,000 population, only 1 out of this 11 will have the disease, or less than 10% will have a disease. So this is one of the important things in screening population. And when you screen it in such situations, so as soon as you see a person is HIV positive, don't throw him out of the job. Confirm it with better tests and more important tests. This is one of the important things in screening populations with lower prevalence. Then the tumor markers. Let us take the example of tumor markers. Suppose I have got an ideal tumor marker, it will give, let us say, a cutoff of 55. And everyone with a value above 55 has got the disease, and everyone below 55 do not have the disease. So this is an ideal and excellent situation, but this never happens in real life. Such a situation, this will be 100% specific and 100% sensitive. But let us see what happens in real life. This is what happens in real life. Even though in the extremes, we may get persons normals and persons with the disease, in between there is always an overlap. Then how do we reach at a cutoff? How do we know which is the correct cutoff, which is the best cutoff to take in these people? So let me take the case of Verma et al. Published in Liver International 2013. They are looking at the sensitivity and specificity of ALT for predicting non-alcoholic steatohepatitis and advanced fibrosis. So when they took the ALT values below 35, the sensitivity was 88.9%. But when they increased the cutoff 52, the sensitivity came down. They still increased to 70, the sensitivity came down to 50. But let us see what happens to specificity. From 28 it increased to 50, it increased again to 60 when the cutoff was 70. So when you change the cutoff, the sensitivity when you increase the thing, the sensitivity comes down at the expense of specificity. You can increase one only at the expense of the other. Similarly for advanced fibrosis. From 68.9, it came to 48.9 and 40, but specificity increased from 22.6, 43.5, and 57.6. So how do you arrive at the cutoff? What is the best cutoff? So there's always a trade-off between sensitivity and specificity. One can be increased only at the expense of the other. And one of the things we use to get at the cutoff is the Udens index or Udens J, which is sensitivity plus specificity minus 1. When you express sensitivity and specificity as percentages, it should be sensitivity and specificity minus 100. That will be the Udens J. Now, cutoff values of D-dimer for prediction of deep venous thrombosis in ovarian cancer. So let us see that as the cutoff of D-dimer increases from 0.5, you know that for till 1.5 the sensitivity is 100. But once you increase the sensitivity, increase the cutoff, the sensitivity comes down, but the specificity increases. Then how do you know the correct cutoff? I was told you, let us see what happens to the Udens values. The Udens index gives the best cutoff at 61.6. So this you can take as the best cutoff for D-dimer in these patients. So that is using the Udens J. But the next method that we use to identify the correct cutoff to compare diagnostic test is the receiver operator characteristic curve or the ROC curve. As you see, the ROC curve has got the true positives in the y-axis and the false positives in the x-axis. So an ideal test would have the left top or top area will be the ideal test. Will have a mark here because it will be 100% true positive and with a 0% false positive. So this receiver operating characteristic curve is a graphical plot that illustrates the diagnostic ability of a binary classifier system as its discrimination threshold is varied. That means that if you have got let's say an alpha fetoprotein, and what is the different levels of cutoff? Let's say I am taking alpha fetoprotein as 10 as the cutoff. So what is the true positive values and what are the false positive values? And then it increased to 50. What are the true positive and true negative values? And as you increase the values, what are the true positive and true and the false positive are different levels of cutoff. And you plot this and you get what is called the receiver operator characteristic curve. And this curve is important. And for example, this is the CA549 in the diagnosis of breast cancer. See, here is the 80% is the true positivity, only about 10 or 12% false positivity. This will be an ideal cutoff for CA549. The area under the curve is also used to compare different diagnostic tests. For example, you compare CF549 with CEA. You see that CF549 has more greater area in the curve, so it can be assumed that it may be a better test than CEA. Let's take, for example, the Diagnose of Alzheimer's disease. Here is the green line shows the ROC. When you take the age as the cutoff, no, it is as good as a random only, like tossing a coin, not at all a useful test. But when you add the ApoE4, when you add the ApoE4 status, the curve moves upwards. And then when you add the rapamycin response, lymphocytes again moves upwards. And when you combine rapamycin response with ApoE4 gene, still higher up. So you can compare the different tests by drawing the ROC curve in the same population. So now this is an ROC curve for ALT to diagnose advanced fibrosis in NASH. See, it is going along the 45-degree angle. It is as good as a random. It is a useless test. It is useless to diagnose advanced fibrosis in NASH. So this is one of the things that we should know is what's called the QADAS. QADAS is a tool for quality assessment of diagnostic accuracy studies, and people who are interested in reviewing articles on diagnostic tests, I encourage them to read this article on research methodology where there is quality assessment of diagnostic accuracy studies, where you look at different aspects like selection criteria, reference standard, and the bias involved and a lot of things. But I'm not going to the details of these things, but I will mention a couple of bias that can occur in studies of diagnostic tests. Let's see, this is a study in which people have done a biopsies in person with normal ALT and elevated ALT and found that 10.7% had normal ALT and 10.7% of people with normal ALT at NASH, whereas 28.9% those elevated ALT at NASH. And these are, the biopsy in persons with normal ALT, which I think many ethics committee would not have agreed to these things. But we see that one of the problems in when the test is normal or when the ALT is normal and all of that, you don't go and examine these people in detail. So this is what is called as a verification bias. So many studies you should see whether all the cases have been verified equally, and in the absence of this, there is verification bias may be there in the studies. Another important thing that I would like to say here is about the positive predictive value. For example, the NICE model, the positive predictive value is 90 and negative predictive model is 91. Let's take the positive predictive value. We know that if a test is done in a referral center where you get cases with advanced disease, the positive predictor and the proportion of cases are more, and you know that the positive predictive value will be more. So the positive predictive value and the behavior of a diagnostic test depends upon the spectrum of cases that you see. And when you compare different studies, we should see whether there is any spectrum bias involved. This is an important thing that we have to look into. And importance of blinding. Let's say that I'm doing a study comparing clinical examination and ascites as diagnosed by ultrasound. And if the clinician does not know the ultrasound findings, it's likely that his results may be different than when he knows the thing. So if you look at the shifting dullness and fluid thrill and comes out with the presence or absence of ascites, if a person who is not blinded may have a greater sensitivity and specificity in his clinical examination. So this is what you call the review bias, because people, when you are doing such studies, it's essential that they are blinded. So we'll come to the end of the session. We finally say and the pretest probability of the test, and then finally no test is 100% perfect. Thank you.